Etti ti questo teatrale.
It's good.
Good evening, Dr. Yoshimoto.
Good evening. Can you hear me?
How are you?
Good. How are you?
I'm good.
Fine.
So we'll just start in 2 to 3 minutes. We'll just wait for another 2-3 minutes before we start.
Yeah.
You may just check in your presentation. If you can just share your screen and check it once.
Yes. Okay. Let me check my slide. All right. Can you?
Yeah, this is good.
This slide. Okay.
Yeah.
All right.
So we'll. You can just stop sharing now. We'll give you have an introduction, and then we will start after a minute.
5 minutes. Okay.
Yeah. So we'll
Right.
start with the introduction after some time.
Please tell me the timing.
Yeah. So you have your you can take your time. You can take 30 to 40 minutes for your presentation.
Oh, I'm already anyway. Anytime is okay.
Yeah. So I'll just let you know. I'll just start the introduction and then you can take over.
All right. So just okay. Let me get started. Okay.
No. I'll wait. I will introduce you. After that, you please start.
Okay. All right.
Good evening, everyone. It's a pleasure to welcome you all to Mahamana Case Discussion Series. Mahamana Case Discussion Series was started 5 years back with a vision of creating an academic platform for all the head neck surgeons, radiation oncologists in the field of head neck oncology to enhance their knowledge, to have a multidisciplinary discussion. So today I take privilege in introducing Dr. Seiichi Yoshimoto, MD PhD, graduated from the University of Tokyo in 1991 and completed his residency in otolaryngology at the same institution. In 1995, he joined the Department of Head Neck Surgery at the Cancer Institute Hospital of the Japanese Foundation for Cancer Research. And in 2001, he completed clinical fellowship at the University of Pittsburgh. Since 2008, he has been affiliated with the National Cancer Center Hospital in Tokyo, where he was appointed Vice Director in 2021. In 2024, he assumed the presidency of the Japan Society for Head Neck Cancer and currently serves on the executive committee of IFNOS and the executive board of ASHNO. He has authored 120 English language papers, 121 Japanese language papers, and 11 textbooks. His clinical and academic interests include sentinel lymph node biopsy, head neck sarcoma, open conservative surgery, skull base and upper mediastinal surgery, salvage surgery after chemoradiotherapy, surgical education, cancer registries, and terminal care for patients with head neck cancer. Welcome, sir. And you can start with your presentation.
Okay. Thank you very much for kind introduction. Today I'm going to talk about surgery for locally advanced laryngeal cancer for 30 minutes. This time I'm very happy to have the presentation. The topic is now first is surgical approach for the local advanced laryngeal cancer. You know, recently we have many technique about transoral resection, laser surgery and endoscopic section, and in Japan also the endoscopic the laryngopharyngeal surgery and transoral robot video surgery. But I think that also the in Japan transoral robotic surgery is available. Recently with Da Vinci Xi to the single port was introduced to head and neck. So I think the single port is very best a good method material for the especially the oropharynx and hypopharynx but I think that still there is an importance of the open resection. Open resection so makes can make the reliable the vertical margin control, and the combination with the next section and prevention of unexpected fistula. So let me compare open surgery and then the CRT. CRT is organ preservation, but sometimes through the organ is preserved, the mucosal dryness and edema may occur. That's why so sometimes the function is not preserved.
Sorry to interrupt you, sir. Could you please make it full screen?
Screen?
Mode of presentation. Yes, could you please make it full screen?
My
Presentation.
face?
Presentation view.
It's
The
okay?
presentation view for the slides.
Yes. You cannot my slide. You can see my slide.
You can see your
Right.
slides, but then
Oh.
it is not in the presentation mode.
Oh, for me this presentation mode, but I'm sorry.
The slides are not moving.
Okay. This is not slideshow.
You can just press F5, function 5, F5.
Function file. Okay. I changed the setting. I think this is no.
It's the first option on the top bar. Yes, the
It's
first
okay. Now it's okay. No,
one. Not yet.
not yet. Okay. Sorry. It's okay. It's okay.
Dr. Seiichi,
You can see a red marking here at the lower corner.
It's okay.
You can just press it there on the presentation mode.
I already did the presentation mode, but okay. Once all right.
You have stopped sharing now.
Now it's up here, but let me check again. Sorry. It's okay? No, not yet.
Yes, we can see it now.
Okay, all right. Okay, sorry. It's okay?
Yes, sir.
All right. Then so there was many methods of the treatment of the laryngeal cancer. So radiotherapy and then the surgery, but the surgery with so many the variety. Vertical partial laryngectomy, the horizontal partial laryngectomy, and the subtotal laryngectomy, and the extended partial laryngectomy, and then the total laryngectomy. So, but radiotherapy is the simple, but the surgery is very complicated. The many technique. So, for example, let me show the horizontal partial laryngectomy. So, I think that for T3 and T4 supergalactic cancer, sometimes horizontal partial laryngectomy is possible. For such a case is open surgery. Recently, many transforal surgery is possible, but still some cases need this horizontal partial laryngectomy, and also the supraclavicular laryngectomy is a very good indication for the tumor just little bit invasion to the paraglottic space. So for such a case, this case is supraglottic cancer T3, and then we did supraclavicular laryngectomy, and after that, here this show the partial view, and then let me talk about the difference between the vertical partial laryngectomy and the supraclavicular laryngectomy. I think the most important thing, the difference of the approach is anterior approach and the posterior approach. So vertical partial laryngectomy is just anterior approach, but on the contrary, supraclavicular laryngectomy with a posterior approach. That's why if the tumor invaded to the paraglottic space of the anterior area, so supraclavicular laryngectomy is better for such a case. And then sometimes the extended partial laryngectomy is very good indicated for the tumor invaded critical arytenoid joint. So this section line here, and then the form.
Dr. Yoshimoto, sorry to interrupt. I'm really sorry. The slides are again not moving. I'll just give you a guide. If you can press this button, can you see the annotation?
Yeah. Okay. Well, you can see here.
So if you can just press the presentation mode, then it may start.
I'm sorry. Is it still any trouble?
Yes, we are not able to see the slides. It's not moving forward. It is stuck at the open section.
Really?
Yes, slide.
Okay. I'm not sure to find my slide. It's sorry. I don't know.
You can click on this.
Okay, I again. This one. So give me time. Can you see my slide?
we are able to see your slide.
Still not in the presentation mode.
You can click on this.
So till
You can see the slide? No?
we can see the slide, but it is not in the presentation mode.
Oh. Oh. I already off my presentation mode, but so that's why I don't know why the Okay.
You can click on this slideshow.
All right. You can see the
Yes,
my
yes.
slide, all right?
Yes.
slideshow.
Okay.
We
Okay.
can see it now. Thank you, sir.
Okay. I already told the difference between the
Yeah.
partial
Yeah, this is
partial
good.
partial.
This will work.
Good. Okay. Partial glossectomy, laryngectomy, and supraclavicular laryngectomy. So as I told you, so even if the tumor embedded into the paraglottic space anteriorly, so I think that the anterior vertical partial is sometimes dangerous, but supraclavicular laryngectomy is better for such a case as the tumor with little invasion to the paraglottic space. Okay, and then sometimes extended partial laryngectomy needed. So if the tumor invaded to the clavicle arterial with the joint, so then we cutting this line, and then reconstruction by the forearm flip-flop. So this is a picture of the tumor invaded into the critical arterial joint, and then we reconstruct by the flip-flop, forearm flip-flop. So sometimes it's needed. So, and also this is a young patient. This is synovial sarcoma, so we did a wide resection, including the CA joint and the forearm flip-flop here, right? And then this is another case, the liposarcoma, and also the tumor embedded into the CA joint, and we did forearm flip-flop here, right? Sometimes needed such operation, right? And then this is a total laryngectomy. So total laryngectomy with always should be coupled with a TE shunt, I think. I think TE shunt is not so bad, boys, right? So now the surgeon had to run the various technique for the conservative surgery. So we may not want to miss the opportunity for laryngeal function, right? So and also the second topic is the management of the cervical lymph node. So we had to have a knowledge about so lymphatics, and then sometimes lymph drainage is between the thyroid cartilage and the hyoid bone here, and then between the clavicle cartilage and thyroid cartilage here. So and also the paraglottic space, and then the pre-epiglottic space, and so contralateral the paraglottic space. There is no barrier, so that's fine. And so especially the midline is no barrier, so that's fine. And so supraglottic cancer is easily to bilateral lymph metastasis. So then this is basically policy with here. So on the supraglottic area, the bilateral, and the subglottic area, ipsilateral, bilateral level 6. And then in Japan, data show the total laryngectomy and the next section data. In Japan, very so many elderly patients had the total laryngectomy, and then sometimes for the elderly patient, no prophylactic neck dissection. So, but survival rate is not so bad. So that's why now we started this clinical trial by the multicentric center. So the randomization for the patient with the total laryngectomy N0 case, and arm A with elective neck dissection, prophylactic neck dissection, and arm 2 is only the paratracheal dissection. That's the way it started. And then finally, I'm going to talk about the total laryngectomy. Surgery, including the total laryngectomy, still remain in high demand, we think. So advanced cancer, especially the recurrence after radiotherapy, so total laryngectomy is still needed. And also in Japan, many elderly patients, for example, especially the patients with comorbidity such as renal dysfunction, and also the patient with poor pulmonary function or history of pneumonia. So this advanced laryngeal cancer need the total laryngectomy. And also the patients have high future risk of the aspirational pneumonia. Also the total laryngectomy needed, I think. So I think the functional preservation is complicated, not simple. For example, even do the CLT, sometimes the still the elderly patients had swallowing problems. So and sometimes the risk of the aspiration pneumonia. So maybe the swallowing without aspiration is more important for the elderly patients. And then also the recently is a shunt speech, TE shunt using the products is very so popular in Japan. So that's fine. So I think the making the voice can be possible even after total laryngectomy. And then the many pharyngeal closure method. So we try to the many methods, one line closure and T-shaped closure, but my bottom line is a T-shaped closure is better because the less tension, and then also the Gambi methods. We like the Gambi method. We tried Japan method, the stapler method, but in Japan not so popular. The Gambi method and the T-shaped closure is a mainstay for the technique of the pharyngeal closure. And then sometimes use of the pectoral major flap in salvage case. And then if the tumor invaded the tongue base or the piriform sinus, so we like to use flap, PMMC flap and under side flap. Okay. And then so T-shape have the 3 point. Sometimes someone is concerned about the visual rate of the 3 point area. So we always use this modified Gambi technique. So I think I recommended this method. So this is a video of the total laryngectomy. Let me show the video. You can see a video.
Yes, we can see it.
All right. After the total laryngectomy, it checked end of the mucosa, cutting end of the mucosa for the blood supply, and the products insertion, and starting the Gambi or the primary closure. most important thing is to checking the blood supply of the cutting end of the mucosa, and then finally adjust the size and less less tension position. Right, it can be here. Right. D shape. Right. And make sure the diameter of the closing the pharynx. And finally, we always do the leakage test. Oh, I'm sorry. The leakage, so saline to the injection from the nose to pharynx and check in the leak, right? Let me go back to the my slide again. Sorry. All right, and then after operation, use a high pillow, the post-operatively release the tension and the cement compression, and the proton pump if it's needed. I think the compression is here, right? And then probably the fifth post-operative day, you can check the leak test. And also the more important thing, creating the self-permanent tracheostoma. So sometimes trouble of the tracheostoma is very, very so dangerous. So that's why we always check the blood flow to the tracheal stump. And sometimes thyroid is preserved to the for the supplying the blood to the end of the trachea, and also reduce the tension at the submental area. So that's fine. So the cervical skin flap should not be pulled down. Otherwise, on the contrary, the anterior chest skin is elevated to the here, and then release the tension is very important. And sometimes cutting the clavicle head obliquely, also the very good method. This is a more video. Just cutting the clavicle head obliquely and making the straight line to the trachea, and also the undermine the anterior chest skin, and then the angle suture between the subcutaneous tissue to the periosteum of the clavicle head, and for the releasing the tension, and then the gently to the trachea end. Don't pull down the cervical skin. Just pull up to the anterior chest skin. It's very important for the making the safely common tracheostoma. Okay, and we always suture between the skin and the trachea end. Sometimes observable using the observable slings is okay here, right? And if fistula developed, I think that with a small fistula, sometimes conservative spontaneously improve, but So maybe I think even the spontaneity is closed. Sometimes in the long term, the stenosis may occur. So sometimes the partial laryngectomy dysplasia with a really high rate happen. So also the thing, for example, is for the two small fistula, local flap is possible to cover the fistula, but I think always even if it's a small fistula, so create the large external fistula, pharyngocular stoma, and then you using the PMMC the cover, and then making a big the pharynx. I think it's very important for the keeping from the stenosis for a long time. So that's why small fistula is more difficult than the big fistula. So that's why even if it's a small fistula, so please I always recommend in the open and making the pharyngocular the stoma, and then the secondary close is better, I think. And recently the robotic surgery for the total laryngectomy is very popular, but in Japan the robotic total laryngectomy is not covered medical insurance in Japan, so that's why we don't have any experience about the robotic surgery. So this is my final slide. So locally advanced laryngeal cancer, you can do the CLT, but I think the CLT is not always for the not always good for many patients. And then after CLT, if patient has a recurrence, only the one choice of the total laryngectomy. But that's fine. So we had to surgeon, especially the surgeon, had to be familiar with the variety of the larynx preservation surgery, and also the total laryngectomy. So many important technique for the pharyngeal closure, and then decrease in the risk of the fistula. Also I always think that some mental death space is very important. And then TE shunt is also very important for the total laryngectomy. Thank you very much.
Thank you very much, sir. That was a very good presentation and excellent demonstration of surgical technique. And you also showed how to deal with complications, how to avoid complications and manage difficult situations. Thank you very much. Are there any questions for Dr. Seiichi Yoshimoto? If there are any questions, you can put it down in the chat box. And also,
so I have a question. I would like to know whether you use any conduits or the salivary bypass tubes? What is your experience in that?
Bypass? I'm sure that I could you ask me again? I'm sorry.
Do you have any experience in using the salivary bypass tubes? Or
No.
Okay.
When there was a fistula?
No, prior, just at the time of the primary closure of the pharynx, do you use salivary bypass tubes?
No. Probably that's your tube is just for the products insertion. So I always do the I always do the products insertion. So one stage operation. So during the total laryngectomy, we always do the products insertion, but no stent tube. So for when we do the primary closure. Okay.
Okay, thank you. Thank you.
You can view, if somebody has missed this lecture, you can view it again on our YouTube channel, Mahamana Head Neck Oncology. Now we'll move on to the next session, that is case presentation. Today's case presentation will be done by MCH resident from CMC Vellore, Dr. Dilip Babu, and he'll be presenting a case of Laryngeal Ca. And today's moderators for the case discussion are Dr. Devendra Chaukar, sir. He's a Principal Director, Head Neck Oncology, Nanavati Max Hospital, Mumbai. Dr. Krishnakumar Thankappan, he's a Professor and Head in Amrita Hospitals, Kochi. And Dr. Anand Narayan, he's a Consultant Radiation Oncologist, Kovai Medical Center and Hospital, Coimbatore. And I also request Dr. Yoshimoto to join the case discussion.
Okay.
Thank you, sir. Welcome, everyone. And Dr. Dilip, you can start sharing your slides.
Ma'am, am I audible?
Yes, you're audible.
Good evening, all. Good evening to the judges. I'm Dilip from CMC. I'm presenting a case on laryngeal malignancy. So my patient, a 65-year-old male from West Bengal, is a ex-serviceman by profession. He came with a complaint of hoarseness of voice from the past 7 months. He was apparently normal 7 months back. Then he developed hoarseness of voice, and it is insidious onset and gradual progressive in nature. The voice change is hoarse in nature and it's persistent throughout the day. For that, he used conservative management at hometown, but still it is not resolving. There is no history of any difficulty of breathing. There is no history of any painful or difficulty in swallowing. There is no history of any cough during swallowing. There is no history of any pain or earache. There is no history of an excessive cough or no history of any fever or cough with bloody sputum. No history of any swellings in the neck. No history of any loss of weight or appetite. Past history. There is no history of similar complaint in the past, and there is no history of any surgeries in the past. The patient underwent dental extraction 5 years back for the dental caries. Family history is no history of any malignancies in the family. Comorbidity is nil. His personal history is a sleep normal, bowel and bladder normal. Diet is mixed diet. He used to consume smokeless tobacco in the form of kini, and for the past 20 years, and after that he's reformed from last 2 months. He's a habit of smoking 3 to 4 cigarettes per day for the past 30 years. Packets is 3. History of consuming alcohol
All
occasionally.
examiners there. Sorry, Dilip. Do we have all the examiners?
Sir?
Hi, Asim, I'm here.
Okay.
Sir, anything? Hello, sir?
Yeah, please continue.
KK there? Is KK around?
So he's caught up in a case. He'll just join in sometime.
All right. Good. So, Dilip, this is Dr. Chaukar here.
Sir.
Dilip, you said in your history, when you were giving, you asked for earache. Why do you ask for earache in laryngeal cancer?
Sir, there is referred notalgia from the laryngeal malignancies. It is afferent is mainly by the recurrent laryngeal nerve, and afferent is going to the
recurrent. Sir? Is it a recurrent laryngeal?
Yes, sir. And superior
laryngeal. Going to the vagus.
Yes, sir.
Yeah. Okay, all right. Go ahead.
Sir, summary of my case, sir. A 65-year-old male with persistent progressive hoarseness of voice for the 7 months with no comorbidities, is a chronic tobacco chewer and smoker, and occasionally alcoholic, sir.
All right. So what do you want to do with him?
Sir,
how to investigate him further?
Yes, sir. Based on this history, sir, I get there is a lesion in the malignant lesion in the larynx, probably glottic area, sir. So I want to evaluate with further imaging and nasophryngoscopy and DL scopy and biopsy, sir.
Okay. So what do you do first? Tell me the sequence of your investigations. What will you do?
So first of all, I will do the scopy, sir.
Fiber
Flexible
optic OPD
scopy.
scopy.
Yes, sir. Flexible
Right.
scopy.
So do we have the findings of that scopy? Can you show us the findings?
It's the next slide. It is there, sir.
Show it.
So coming to the general examination, is a moderately built and sir, shall I continue or shall I show?
No, continue. Finish your examination, then we'll ask you.
It's
I thought
general
you had finished.
exam.
Okay.
General examination is a patient is moderately built and moderately nourished and conscious and cooperative and oriented in respect to time and place. Is a no pallor, rectus, sinus clubbing and generalized lymphadenopathy. Remaining systemic examination and it includes respiratory system and CVS per abdomen normal. Is ECOG is 1. Pulse rate 88 per minute, blood pressure 130/90, weight is 50 kgs, height is 17 centimeters, BMI is 17.3 centimeters. Coming to the local examination, his patient is comfortable and no noisy breathing or stridor. Voice is hoarse and able to complete full sentences. The oral cavity, the intrinsic distance is 4 centimeters, partially dentate. There is no loose or mobile teeth. Nicotine stained teeth. Oral hygiene is poor. Oral cavity, other subsides are normal. Oropharynx is normal. Base of tongue is normal on palpation. So coming to the neck examination, the laryngeal framework is normal. There is no restricted movements of neck. On palpation, there is no laryngeal tenderness. Laryngeal cryptus is present. There is no palpable lymph nodes in the neck. Thyroid gland not palpable. So this is my flexible scopy.
Sorry to interrupt. Since KK sir is involved, got caught in a case, I request Dr. Elizabeth Ide from RCC Trivandrum to join as a moderator, one of the moderators. Thank you, ma'am.
So this is a flexible scopy that shows a proliferative growth noted in the right vocal cord, extending superiorly into the anterior commissure and posteriorly into the false cords and inferiorly extending into the subglottis and anteriorly reaching into the anterior commissure and posteriorly the posterior commissure is free. Vocal cord movements, there is right vocal cord is fixed and whereas left vocal cord movements are normal. Bilateral AE folds are normal and retroarytenoid area is normal. Piriform sinus and postopharyngeal wall and postcricoid area are normal. Epiglottis, both lingual and laryngeal surface of epiglottis, base of tongue and vallicula is normal. So shall I continue?
Yes, please. No. So you said fiber optic scopy. You said the vocal cord is fixed. Is there anything else that you look for apart from vocal cord fixity?
Sir, we have to see uh, the extension. We have to see, sir. We
Extension.
have
You
to
told me that it is going. The vocal cord movement is fixed on the right side,
yes,
while the
sir.
left is normal. A fold is normal. So you have told me all the extent. So apart
Sir.
from vocal cord, anything else that you need to see? Mobility. Any other part mobility that you need to see? In
We
other words, what is the cause of vocal cord fixity? What are
sir,
the causes of vocal cord fixity?
the other causes of vocal cord fixity, if the lesion is any infiltrating into the paraglottic space,
So
that
one is
time
paraglottic space invasion. Yes, very good. Then
and involvement of the cricoarytenoid joint, sir.
yes. So what
How
will
about
happen
the
when there is
how about
what will
the arytenoid movement? Arytenoid movement
Yes,
is,
sir.
is
Yes,
okay.
sir.
arytenoid? Yeah, yeah.
Arytenoid
So
movement, sir.
I
so
don't
you
move,
have to
but the vocal for the fix.
correct. So you have
Uh,
to tell both Dilip. You have to talk of vocal cord mobility and arytenoid mobility.
Movement.
Because vocal cord mobility can be lost because of two reasons. The first one you said is paraglottis, and the second is also just because of the weight of the tumor, even without paraglottic. And you have to differentiate this because your treatment will differ depending on what you find. And the third is, as a professor said, is cricoarytenoid joint involvement or arytenoid fixity. Now, these all three have different meanings and different treatment outcomes. Okay.
Okay, sir.
So when you say vocal cord fixity, you have to define whether it's. I mean, you have to tell me vocal cord and arytenoid at the same go. All right.
Okay, sir.
Okay. Go ahead.
So, next thing, sir. Coming to the diagnosis, sir. This is my case is a case of neoplastic lesion of the larynx. The subset is a glottic carcinoma glottis, stage CT3 N0 M0. Final stage is confirmed after imaging, sir.
What imaging do you want to do?
Sir, for laryngeal malignancies, initial investigation of choice is contrast enhanced CT from head and neck and thorax, sir.
What? Sorry, I didn't get it. What
Sir,
imaging?
sir, contrast enhanced CT head and neck and thorax, sir.
Contrast enhanced CT of the head and neck and thorax. Why
Yes, sir.
thorax?
Sir, because there is a chance of, in this case, I want to see the there any second primaries in the lung, sir. Because this laryngeal cancers, there is a high chance of metastasis to the lung.
Okay. High chance of metastasis in this patient to the lung.
Yes,
Are
sir.
there high chances of metastasis in this patient? I'm not debating with you. I'm not saying you're wrong. What are the when will you find higher chances of metastasis? This is a T3N0 patient.
Yes,
Do you think
sir.
this patient will have lung metastasis?
Uh,
The lesion is proliferative.
and it is advanced, sir, the proliferative disease, and
Fair
is
enough.
having is a chronic smoker, sir. So
Right. No, your answer is correct. You will do in advanced case. You will do, but the propensity of lymph node lung metastasis without having lymph node metastasis is low. That you must understand. It is okay to scan the chest when you're doing the scan of the neck. Okay.
okay, sir.
Okay. Go ahead.
Sir,
Is it a glottic tumor or is it a larynx glottic carcinoma or transglottic?
sir,
What do you mean by transglottic?
sir, transglottic tumor is defined as the lesion involving the supraglottis and it spread to the glottic, sir.
Sorry. Come
Sir,
again.
the lesion involves the vestibule of the supraglottis or supraglottic area, and it has to extend it's reaching into the or it's extending into the glottis area, that is called as transglottic tumor, sir, involving more than one subsite.
Right. Not only one subsite. So this is more than one subsite, no? So it's larynx going to subglottis is more than one subsite. Glottis going into subglottis. So is it transglottic?
No, sir. Supraglottic
And what is
region.
transglottic? And what is the
Supra
importance of transglottic tumor? I'm not asking you just anatomy. I'm asking you because transglottic tumors behave differently from glottic tumors. Right?
Yes, sir.
So what is transglottic? It's not two
Trans
subsites. Two subsites is glottis and subglottis is also two subsites.
Yes, sir. The lesion is involving the initially the epicenter of the lesion is in the supraglottis, and it is extending into the glottis lesions. They are considered as
So the one word that you have to tell me, it crosses the laryngeal ventricle. Okay.
yes.
So it's either supraglottis going into glottis or glottis going into supraglottis. Okay. Either ways, it could the epicenter could be anything. Anything that crosses the laryngeal ventricle is called a transglottic tumor. Okay.
Okay, sir.
What is the difference between a transglottic tumor and a glottic tumor? Glottic tumor.
Sir, transglottic tumor, uh, the disease the itself it's a advanced disease, sir. Whereas in a glottis is in a the local disease, sir, and the
Yeah, so transglottic are more aggressive, and the chances of extralaryngeal spread are higher in transglottic. Should be kept in mind when you're examining the patient. Okay.
okay, sir.
All right, go ahead. Elizabeth, you want to ask anything at this one? Ashim, why don't you also join in since KK is not here?
Yeah, Dr. Elizabeth here. I just joined only.
Yeah.
So, so is the examination complete or just the local examination? I couldn't have
Can
you.
you give summary to Elizabeth again?
Ma'am, my patient is 65-year-old male patient from West Bengal, is presented with complaining of hoarseness of voice from the past 7 months, ma'am. He had only complaining of hoarseness, persistent progressive hoarseness of voice. There is no other history, like no history of any breathing difficulty, no history of any difficulty in swallowing, no history of any.
Okay, that's okay. So this is a hoarseness symptomatic patient, and then no referred pain. You were
Yes, ma'am.
discussing that again. And on examination, it was a transglottic growth and fixed cord, right?
Yes, ma'am.
With no neck nodes.
Yes, ma'am.
Oh, okay, okay. And you did a direct laryngoscopy and biopsy. And the biopsy, what is the biopsy report?
Ma'am, biopsy, we did ma'am, this biopsy came as moderately differentiated squamous cell carcinoma, ma'am.
Okay, so you said all about that laryngeal examination, endoscopic finding and all. So along with all these findings, actually the glottic space assessment is also really important because it is a T3 larynx. Why you are really worried about glottic space assessment? What is the importance?
Ma'am, the patient has may develop breathing difficulty. So due to the
Yeah.
advanced disease,
So because it is an advanced larynx fixed
yeah,
chord, you should always be concerned about the space in the airway, right? So, and you are planning for a biopsy. So, what precautions you will go for? You take before going in for an endoscopic biopsy
ma'am,
in such cases.
I have explained the patient prior to the procedure. There is if any chance of breathing difficulty, that time we there we can do the tracheostomy, elective tracheostomy if needed.
Would
Yeah,
you
either.
counsel for a
Yeah.
tracheostomy that is fine for the airway? Sorry, ma'am, please go ahead.
No. No, I was just asking that only. You can proceed.
So you want to do a tracheostomy, but since it's a T3 disease, there is functional larynx, and you are planning for a biopsy. Would you not like to avoid a tracheostomy
Yes,
altogether
sir.
every time?
Yes, sir. Most of the times we want to avoid, sir, because now it is a functional larynx. If I do tracheostomy, so along with the so it may turn into non-functional.
So what would you do to avoid a tracheostomy?
Sir, one thing is I will do the debulking, sir. If intraop on table, I will do bulking the tumor, and
You will do the debulking of the tumor. Why?
sir, because of the disease itself, it will impedes the block, obstructs the laryngeal inlets, sir. So there may be chance of breathing difficulty.
So is there any new evidence or anything that is there that debulking will be helpful or something like that? I'm not sure. I have not read something like this.
Uh, sir,
We may do a debulking with a pedunculated lesion or something which is obstructing the airway. It's a small pedicle that is attached. Then we may resect
if
it.
I
But
can interrupt,
just
if I can interrupt for a minute,
reduce the
Dr.
airway is
Rajiv.
not advisable.
Sorry, Dr. Rajiv Michael here. If I can interrupt for a minute, if you have a,
Yeah, please tell me.
if you have a lesion which is exophytic, partially obstructing the glottis, you need a biopsy. So our policy is at the time of biopsy, if we have a significant exophytic component and there is a luminal compromise at the glottis, to increase the airway as far as possible. If you have an infiltrative or an ulcerative lesion, you're perfectly right. Debulking may not help at all. So very select patients, there is a role for debulking with laser or otherwise, if you can avoid a tracheostomy at the initial setting. That will give you all options open to consider your management. But we haven't discussed imaging yet. So
I was going to ask you, Dilip, you have to
sir,
tell me your CT scan findings. You have not told me. So the
yes,
discussion now was to avoid a tracheostomy. So tracheostomy is
yes.
required, as Rajiv said, in two settings. One, you have an infiltrating lesion that has really compromised your airway. In that setting, this is not a functional larynx. You'll have to do a tracheostomy. The only one scenario, very rare, is that a lesion is pressing and you have what is called as a ball valve effect. That a small pedunculated lesion or a lesion which is pedunculated is causing a ball valve effect and causing. So during that biopsy, you will kind of remove that tumor which is obstructing the airway. So you have a good airway. So you said this is a functional larynx. How, you have only done DL scopy, you have done CT scan. Okay,
Yes,
we are
sir.
going to tell me the findings of the scan now.
Yes,
How do you call this a functional larynx? How do you know patient is not aspirating? Do you do any test or you've not done any test? Or
sir.
you just
Usually we'll do the all cases routine fees we'll do, sir, for
yeah. So you didn't tell us
laryngeal
fees. You just told us
malignancies.
it's a functional larynx.
Yes, sir. So then I will decide whether the aspiration or penetration is there. Based on that, we decide it
At
is a
what score
functional.
of fees? What is fees? Can you tell
Sir,
us?
there is a Rosenberg score, sir,
Right.
penetration aspiration score.
Very
It's
good.
it's at 8 types, sir. So in that type 7 and the grade 7 and grade 8, definitely this dysfunctional larynx. So
Yes.
in that cases, so we can consider
That is aspiration.
as
Gross
aspiration.
Okay.
So in
All
those
right. 5
cases,
and 6 is penetration.
as 5 as a 3 and from 3 onwards, it will penetration starts.
Penetration. Right. Right. So anything above 5, you are careful. 5 or 6, you're careful that this may be because post radiation, the patient can have more aspiration. All right.
Yes, sir.
Okay. Okay. Now tell us the CT scan finding that Rajiv was asking about. Let us discuss the imaging.
Sir, this is a contrast enhanced CT from vertex to diaphragm, sir. It shows
Hello.
sir, am I audible, sir? So this
Yeah,
is a
you are not audible.
contrast,
Just tell us the
contrast
CT finding.
enhanced CT from vertex to diaphragm. It shows a hyperdense lesion in the right vocal cord, sir, and it's extending into the laterally it is extending into the right paraglottic space and anteriorly it extending into the anterior commissure, sir. There is no cartilage erosion and there is no any there is no any nodal diseases, and there is lung also there is clear, sir. There is no nodules in the lung.
Right paraglottis is involved and anterior commissure is involved.
Extending into the anterior commissure, sir. Posteriorly,
And
posteriorly it is abutting the arytenoid, sir.
it's abutting the arytenoid. Arytenoid
Yes,
is
sir.
not involved.
Yes, sir.
Okay. And what about subglottic?
Subglottis is free, sir, and superiorly is extending into the false vocal cords, sir.
So it's a
Very
transglottic
limited.
lesion.
Yes, sir.
Okay. For cartilage erosion, which is a better investigation, a CT scan or an MRI?
Sir, MRI is the high sensitivity for cartilage erosion, sir.
Right.
It's also depend upon the type of cartilage, sir. If it is a thyroid cartilage, it's different. Cricoid cartilage is different, and retinoid cartilage is different, sir.
No, I'm talking about thyroid cartilage.
Yes, sir. In thyroid cartilage, the MRI has a high sensitivity to detecting of erosion.
Right. So when will you do an MRI? Will you
Sir,
do an MRI or when will you do it?
Sir, MRI is usually indicated whenever the case, especially in doubt of T3 or T4 stage laryngeal cancers, if there is any cartilage erosion, and
If there is cartilage erosion, why you want an MRI?
sir, if it's
Because CT scan is very good for an
doubt of cartilage erosion, sir.
doubt. So if
Yes,
CT
sir.
is equivocal, CT is then you do an MRI as a problem solving tool. Because if MRI is negative, then you know there is no cartilage erosion. So when CT is equivocal, then you do an MRI. Okay,
Yes,
to
sir.
rule out cartilage erosion. Very good.
So any other added benefit of doing an MRI in a T4 patient?
Madam, T4?
Any other added advantage for an MRI over CT in a T4
T4
laryngeal
lesion,
lesion?
ma'am, we can see any extra laryngeal extension, ma'am, especially any extra
That will
laryngeal.
be found in a CT scan laryngeal,
Uh,
and as you said, it's for a cartilage invasion. MRI will be helpful. Also in advanced T4. Any
Advanced
other added benefit?
ma'am, we can see the posterior prevertebral involvement
Yeah,
of
especially for assessing the operability,
yes,
prevertebral space
yes.
invasion, esophageal invasion, all those things will be, and mainly the vessel involvement. All these things will be better delineated in an MRI. That is better soft tissue delineation. So for assessing the operability in doubtful cases, and also for the early cartilage invasion, MRI is complementary with CT.
Okay, ma'am.
Right. Go ahead.
Sir, so based on this imaging and history, I'm getting I'll further evaluate the patient. I'm getting a diagnosis as the carcinoma glottis,
Mhm.
CT3 N0 M0.
Mhm.
So further evaluation needed based on DL scope and biopsy. After that, I will.
You did DL-scope biopsy, yes.
Sir.
Yes, you did DL-scope biopsy, no?
So based on the DL scope biopsy, if it is a positive malignancy, then I can decide the
So,
patient's.
Dilip, now somebody in the chat box has written the summary has to be after the presentation, after all the investigations. So I agree. So now quickly tell us the points of your history, of your clinical examination, and of your CT scan, and all the other investigation that you did to decide which will point towards what treatment you're going to do. Give me only the positive things that you. So I know what line of thinking you're doing. I don't want the entire summary. I want these points that you will decide this treatment versus that treatment. Okay?
Sir, okay, sir.
Yeah.
So
Okay. Now go ahead.
based on this, my patient, I want to give this is a functional larynx, sir.
Yeah. No,
So
first start with history. First start age. Age is important.
it's a age is 65-year male patient, sir.
Okay. So it's
With
65.
yes, sir, with no comorbidities and
No
good
comma.
ECOG
Very
score,
good. Then
good ECOG score, and
right. Good ECOG score. Very important. Then
and is a functional larynx, sir.
functional larynx. No aspiration, no cartilage
No
erosion, no
penetration.
stridor. Good.
So along with that, so based on these things, I can plan
I need
non-laryngeal
more. I
surgery.
need more. I need more.
Okay, sir.
What else? I told you in fiber optic.
Based on the
Extend.
fiber, yes, sir. The fiber optic shows the epicentered growth in the glottis and is a transglottic tumor with
Okay.
no cartilage erosion, and there is no lymphadenopathy and no distant metastasis.
No. So
So,
first, sorry, Dilip, to interrupt you. The
sir,
first thing that you have to tell me is that the cord is fixed, but the arytenoid is mobile, or the arytenoid. So once you
sir,
tell me the arytenoid is fixed, that means the cricoarytenoid joint is involved. That largely precludes any conservative laryngeal surgery. Okay. So I
yes, sir.
know you're thinking on these lines. You have thought of it. You have seen the cartilage. You've seen the larynx. If the cord is mobile and it's not reaching the arytenoid, then the arytenoid is free. You may think of some kind of a conservative procedure. If not, if the arytenoid is fixed, the cricoarytenoid is involved, largely you cannot do. I know professor showed us that we can dissect the arytenoid cartilage, but largely many of us will not venture into a patient with a fixed cricoarytenoid joint. Okay?
Yes, sir.
Right.
So in this case, the arytenoid is mobile, sir, but
It's
the
mobile.
cord,
Okay.
yes, sir,
Lovely.
cord is fixed, sir.
Cord is fixed. Right. So it's a paraglottic disease. Yeah.
Paraglottic, yes, sir.
Okay.
So I consider non-organ laryngeal preservation surgery.
Non-organ, non-surgical, you mean?
Sir, non-surgical options for laryngeal preservation.
Is there any conservative laryngeal surgery that you can perform in this case?
Sir, in this case, we can do the open laryngeal, open partial laryngectomies. We can do, sir.
What open partial laryngectomy can do?
In this case, I can do the supracricoid partial laryngectomy is the one option, sir.
Can you do it? Is it an option?
Sir, because of one is a very paraglottic spread is there,
That
and
is okay. In supracricoid, you remove the paraglottis completely.
yes, sir.
Supracricoid, you will remove the paraglottis.
And if and the opposite the ipsilateral arytenoid is also free, and cricoid is also free. So so in this case, it is a I may consider, sir.
Yes, you're right. You're right. Go ahead. Don't help. The only thing that may avoid you from doing a supracricoid in this case is the lesion you told me initially is close to the arytenoid. Though the
Yes, sir.
arytenoid is mobile, if you're not getting a margin, see, any conservative laryngeal surgery, you have to preserve both the arytenoids. Now,
Yes,
in textbooks, they say that even you can resect one arytenoid and reconstruct it, but the function is poor. So, if you have enough space between the lesion and the arytenoid, so that you can preserve the arytenoid by taking the vocal process, only then you will consider a supracricoid laryngectomy is one of the option on the table that you have in this case. Okay.
okay, sir.
Okay. Anybody wants to add anything? Rajiv, Elizabeth, Professor?
So here the interarytenoid area is free, right?
Yes, ma'am. Intraretinoid area is free, ma'am, and post-cricoid
And
growth.
the contralateral arytenoid, A fold, everything is free.
Yes, ma'am.
So as you said, supracricoid is an option. So only thing is the recurrent laryngeal nerve and the cricoarytenoid unit on the other side should be preserved.
Yes, ma'am.
Because one side arytenoid is going to get resected, you have always problem of inadequate airway postoperatively, and aspiration definitely is after a supracricoid laryngectomy. And all these conservation laryngeal surgeries, we are closure of the tracheostoma and also the preservation of the speech. But in some cases, you will end up in permanent tracheostomy because of this neoglottic inadequate airway. That is the issue. So when you resect extensively, and you said either conservation laryngeal surgery or chemoradiation in this case. So
Yes.
other the indications for a total laryngectomy is always a dysfunctional larynx in a T3 larynx. So can you just tell other indications for surgical procedures, not radiation, in T3 larynx?
Ma'am, in this case, ma'am,
Not in this
in
case. Other indications
generally,
for yeah.
CT3 larynx, ma'am, we can do the vertical hemilaryngectomy, ma'am. So the vertical hemilaryngectomy is the one option, along with the supracricoid partial laryngectomy and supratracheal partial laryngectomy is the three options available, ma'am. Along with
Not in this case.
CT3.
Yeah. No, in this case, vertical partial laryngectomy is not an option.
Yes, ma'am.
Okay. No. I was just
why is it
asking.
not an option, Dilip? Why is she saying it's not an option?
Madam, sir?
Why is it not an option in this case?
Sir, here the lesion is reaching up to the subglottis, sir.
If
So
subglottis is involved, then even supracricoid is out.
just reaching, sir. No, but
So
radiologically,
subglottis is not involved. You told me earlier.
yes, sir.
Subglottis is not involved.
Radiologically, it is free and free, sir.
Why is vertical partial not indicated in this case? And give me the indications of vertical partial.
Sir, in vertical partial laryngectomy is not indicated if any cartilage erosion is there.
This
And
doesn't have cartilage erosion.
And if it is the involvement of the arytenoid cartilage or cord fixity,
This
those
doesn't
cases,
have arytenoid cartilage erosion.
yes, sir. And
Give me the reason why you're not doing it. You told me arytenoid is not involved, cartilage not involved. Then why not vertical partial?
sir, in this case, vertical I am not doing because of
Why?
bulky.
Bulky is okay, you can take it out. Paraglottic.
Anterior commissure is involved, sir.
Paraglottic. Anterior commissure, vertical partial, or a bilateral, frontal laryngectomy is the best
Yes,
option.
sir, frontal type.
Paraglottic spread is the disease that precludes the gross paraglottic disease. Very early disease is okay, but gross paraglottic disease is a contraindication for a vertical partial laryngectomy, and that is why in this case the only option on table is a supracricoid laryngectomy if your subglottis is free. The only possible option is a supracricoid laryngectomy. Okay.
Okay, sir.
So early paraglottic or minimal paraglottic, you can still get away with vertical partial, but generally paraglottic disease, you precludes vertical partial laryngectomy, especially for a T3 cancer.
Okay, sir.
So
Okay.
for
Dilip,
this case, if you are going in for a surgery, this is only supracricoid is the only option, no other conservation laryngeal surgery. So my question was, what other indications in a T3 larynx to go for a surgical management? The answer is like non-squamous malignancies, like a sarcoma or a adenoid cystic carcinoma of a larynx. If it is T3, you cannot send the patient for a primary radiation treatment. Then you have to go for a surgical management. Otherwise, for a T3 squamous cell carcinoma, you can opt for a chemoradiation. That is the answer. For a sarcoma or a non-squamous other minor salivary gland malignancy, the option is only surgery, not for radiation. Okay.
So Dilip, come on. So now this is a T3 N0 M0 transglottic tumor. What options are you going to discuss with the patient? It's a functional larynx. Patient has no stridor. Patient has no aspiration. Now, what options are you going to discuss with the patient?
Sir, I can explain both surgical options and non-surgical options, sir. But in surgical options, I can explain the patient there is a need of tube, like it include both feeding through the NG tube dependency or feed gastrostomy dependency.
Sorry for what?
Sir, for tube feeding, sir, for dysphagia is there, patient have dysphagia, so I may explain.
In surgery?
No, surgical options also I can explain, sir, because of
What?
his.
Fine, fine. Okay, so you'll tell him what surgical option will you tell him?
Sir, I can explain open partial laryngectomy options to the surgery, sir. So
Mhm.
for the patient, to options like two options I'll tell, sir. One is non-surgical option, concurrent chemoradiation, and surgical options I'll tell open laryngeal surgeries like supra-required partial laryngectomy. In that there is a tracheostomy tube dependency is there, and feeding tube, Ryle's tube feed or gas.
I'm not sure with the supracricut. Why should there be a tracheostomy dependency?
Sir, in not all cases, sir, but initial,
No, no, very less. I
initial.
don't think this answer is correct. You're getting into something that is not called for. I don't think supracricut. Nobody would have done supracricut laryngectomy with tracheostomy and feeding tube dependency. So if indicated, you have three options in this case. One is you said is organ preservation, non-surgical, right?
Sir,
You said that. The second is a conservative laryngeal surgery, if possible, if the arytenoid is free. Okay. And third is?
concurrent
No,
chemoradiation.
that is the first. That is
The
organ
first,
preservation, non-surgical. Surgical is supracricut, and third is, which we used to do earlier, which you would not do in this case, is a total laryngectomy.
total laryngectomy, sir.
Okay. So now what you are doing in this case? What do you want to do in this case?
Sir, in this case, I want to do CCR. I want to preserve the larynx, sir.
Right. So what will you do? How will you preserve it?
I will opt non-surgical options, concurrent chemoradiation.
Right. So what investigation will you do before you give concurrent chemoradiation to this patient?
Sir, I can check the patient routine blood picture, sir, CBC. Along with that, I also check all the creatinine profile, sir.
Very good.
Along with that, I will see all the counts, WBC.
Anything else? Anything else? What
Sir,
concurrent? What medication? I mean,
sir,
what is the concurrent thing?
yes,
What is
sir.
what is the drug you want to give?
Sir, usually based on the evidences, cisplatin with 5-FU is a standard drug, sir. In those
Cisplatin
cases,
with 5-FU for confidence?
5, yes, yes, sir, cisplatin with
With
5-FU.
5? Really? I'm not sure this is the correct answer.
Because of evidence.
Concurrent is cisplatin with 5-FU? What trial are you basing this on?
Sir, RTOG 9111.
9111 was the CTRT arm?
Yes, sir.
What was it? Was it cisplatin 5-FU?
Yes, with
What was the arm? What are the three arms of RTOG
sir,
9111?
in that 3 arms are induction with the RT, along with concurrent chemoradiation, along with RT, sir. Oh, that.
Yeah. So what was the arm? Was it 5-FU?
Sir, there is a weekly.
3 arm bolo. One was radiation alone. Second arm was NACT followed by RT. And the
sir.
third arm was?
Concurrent chemoradiation.
What was the concurrent chemoradiation? Was it cisplatin 5-FU?
Yes.
Why are you giving 5-FU?
Sir, because of for tumor control and.
So what was the third? The third arm was not 5-FU. The CTRT is cisplatin.
Yes, sir.
Concurrent cisplatin. What was the dose?
So cisplatin, they're giving 100 mg per meter square, sir.
Correct. Every
3 weekly, sir, like first week and 20.
So it is only cisplatin, not 5-FU. Okay.
Oh, sir.
Cisplatin 5-FU was given as neoadjuvant chemotherapy. All right.
Yes.
Okay. So what will you check before? So cisplatin is the drug that you will give,
Yes,
right?
sir. Audiology I will do, sir.
Right. So you have to first check the patient for eligibility of receiving the intended treatment that you're giving. So if you're giving cisplatin, you have to check his creatinine clearance and you have to check his hearing, audiology, or
yes,
audiometric assessment, right? Because it is ototoxic and nephrotoxic, correct?
Yes, sir.
Excellent. Now this patient is not cisplatin. He's not eligible for cisplatin. Now what will you do?
Sir,
it comes back that he's not eligible for cisplatin.
So then I can
Before I go there, apart from 100 milligram per meter square, is there any other regime that you can give?
Sir, usually in India, we will give 40 mg per meter square, sir.
Right. So you can give a weekly regimen or you can
Yes,
give
sir.
a
Weekly
3 weekly.
regimen or 3 weekly regimen, sir. 60 mg meter square, sir, in India.
Excellent. So now the treatment is concurrent CTRT with cisplatin, 100 milligram 3 weekly or 40 milligram per meter square weekly. Now this patient is not eligible for cisplatin. Now what will you do?
So then I can give other platins, sir. Carboplatin I can give, sir. If
Give
it
me the
is a
options. Give me the options.
if it is not a platinum resistant case, or then I can give the carboplatin, sir. If it is a patient is platinum refractory or platinum cases, then in those cases I can opt other immunotherapy also, sir.
No, don't beat around the bush. So you will give, if not cisplatin, you will give, what will you give? What are the options? You quickly tell me. 1, 2, 3. Sir, I'll do this. Tell me
Sir, if
quickly.
it is a carboplatin, I can try, sir. Carboplatin. If it is cisplatin, is not eligible.
Then what else can you try? Dilip?
Sir, hello, sir.
RT alone an option.
Sir, I am not audible, sir.
Is RT alone an option? Can you hear me?
RT.
Radiation alone without cisplatin.
Yes, sir. If it is a patient is not eligible for platinum,
Yeah.
then I can opt for RT, sir.
What are the disadvantages of giving RT alone?
Sir, if disadvantages giving RT alone, the laryngeal preservation rate is less, sir, and
you get a lower control rate, but not a difference in overall survival. Correct?
overall survival.
Right.
Yes, sir.
Is RT plus something else? Something else you want to add in RT? Instead of carboplatin or cisplatin, you cannot give platin. Now, what will you want to add?
Rituximab I can add, sir, if it is
Rituximab. Very good. So,
yes, sir.
so ऐसा बोलना Dilip, you know the answers. So you say if the patient is not eligible for platinum, then I would counsel the patient for receiving only RT if he is very keen on RT plus rituximab, or only RT if he is very keen on preserving his larynx, explaining him that there is an inferior laryngeal control rate with RT alone. The chances of salvage laryngectomy are higher.
Yes, sir.
Okay, and also on the table is your total laryngectomy. You never take it off the table.
Okay, sir.
Okay, because the control rates, it has never been shown that organ preservation is superior to total laryngectomy in terms of control rates, right? It is an
Yes, sir.
option with the patient. So because salvage has its own complication, you have to explain all this to the patient, those who are cisplatin ineligible. Okay?
Okay, sir.
What about induction chemotherapy? Why would you not give induction followed by so what are followed by RT? Can you give induction followed by CTRT? Isn't it better? Shrink the disease and
Sir,
then
the trial done by trampoline trial, sir. In that, they tried initially with induction followed by concurrent radiation therapy, sir. But in those cases, the trial is mentioned that even though the laryngeal preservation rate is very high, but the toxicity is very more.
Right.
The control rates is also very poor with the those things. So that's why the trial is slow accrual and it stopped.
Excellent. So induction followed by concurrent CTRT has not shown any benefit. There are a couple of trials. One is the trial you showed. There's a DECIDE and a paradigm trial also in advanced head and neck cancers, which have not shown any improvement in survival with induction chemotherapy followed by CTRT, and the toxicity is higher. Okay, so that is out. So what about induction followed by RT versus CTRT? Which will you prefer?
Sir, induction, CC, concurrent chemoradiation with RT is a preferable thing, sir, than induction with RT, sir.
Okay.
This,
Why?
because, sir, the veteran affairs trial quoted that it is even though the laryngeal preservation rates is better with sorry, sir, I was missed.
No, you're right. You're saying the ulta. Concurrent CTRT has a higher laryngeal preservation.
Yes, sir, high laryngeal preservation, and the survivability is similar in all the three groups. And so in those cases, concurrent chemoradiation will be beneficial to the patient in if you think about laryngeal preservation.
Very good. Okay. Any question, Elizabeth?
Yeah. So
Can I have
please you tell me when you are planning patients. So for today's era, we are going to do CTRT. Now, if you have to plan a salvage laryngectomy and we want to do a supracricoid or a partial laryngectomy in a recurrent setting, Can we do that?
Sir,
And what are the indications of doing that?
sir, Piaget group mentioned that there will be a chance of conservative open partial laryngectomies in case of supposed uh, salvage patients, sir. But uh, the chances of relation post-op complications are more than 50 to 60% in cases with doing conservation in those cases, sir. So I prefer, but this T3, T4
Agreed. So we agree that there will be higher incidence of complications, but suppose you have to select a patient for partial laryngectomy post CTRT. So what will be your prerequisites and how will you select that patient?
Sir, if it is if I plan for open the early stage, early recurrent T stage, sir, recurrent T1 and T2 stage, those cases I can consider, sir. And the larynx should be function, and it should be no functional larynx is needed, sir. There is no aspiration or no penetration, and the bilateral arytenoid should be free and it's mobile and remaining hypofyring post.
So those are the prerequisites that one of the prerequisites. What are the tumor related in the per primum for the first setting in the first treatment when the patient was going for CTRT? Would you like to have the evaluation of that tumor at that time?
Sir, based on imaging and once after first cycle, I will assess the patient response based on
No. You're confusing. See, so the patient has been selected for CTRT. Post CTRT he has a recurrence, and you
Yes,
are
sir.
planning for a conservative laryngeal surgery.
Yes, sir.
So you would like to evaluate what was the disease status
Yes, sir.
prior to your treatment, whether the disease was conducive to undergo a partial laryngectomy in the per primum setting or not.
Is
If the
there any
disease is not
response?
conducive of a per primum for a partial laryngectomy in a per primum setting, it may not be conducive to do a surgery later on as a partial laryngectomy after CTRT or after a recurrence.
Yes. If the recurrence lesion tumor stays is needed, sir, for this based on our imaging.
So that's what I'm saying. So when the disease is not conducive for a partial laryngectomy to begin with, in the first instant when you are giving RT, the disease will not be conducive to do a partial laryngectomy after a recurrence.
Yes, sir.
Okay, Dilip, I'll ask you a simple question about. So now you've done, as Asim said, you've done, and the patient recurs. What percentage of patients post radiation recurrence can you do a partial laryngectomy versus, and what percent you will have to do a total and why? In literature, what is given? What percentage undergo total? What percentage will undergo partial? Can undergo partial? Give me a ballpark figure, or what do you think it is?
Sir, total laryngectomy rates based on CCRT is 38%. If I use induction with RT, if I use only
No. I'm saying there is a recurrence.
recurrence cases.
Now recurrence,
Okay,
what
recurrence,
percentage? You are talking of conservation, right?
Oh, sir.
And what percentage of these patients can you really conserve the larynx, and how many percentage will land up with a laryngectomy?
Sir, there is only 10 to 15% of the patient only.
Excellent. Why is that?
Because, sir, most of the patients after concurrent radiation therapy, the patient larynx is deteriorated because of chemo and RT related toxicity. So most of the larynxes are dysfunctional. Even if it is a functional also, the patient.
Something more with the biology. Majority of the larynx recurrences are higher stage, number one. Number two, autopsy studies have shown that sometimes you can have multicentric recurrences.
Yes.
And that is why it is unsafe to do partial laryngectomy in locally advanced laryngeal cancers. All right, those are failed radiation. As Asim said, if it was a smaller lesion, was amenable to partial laryngectomy earlier and is still is a small lesion and amenable, only then you can do so. You are right, in 10 to 15% only, you will be able to conserve the larynx post radiation. Otherwise, you will have to do a total laryngectomy. So 80% you will do a total laryngectomy.
Total laryngectomy, sir.
Right, very good. So Dilip, we are close to 7. Any other question? We have a radiation oncologist. What about the fields and all? Yeah, please.
Yes, sir.
Anand,
Dilip,
please
I'm Anand Narayan. I'm a radiation oncologist. I agree with almost all of the discussion that happened regarding radiation. The only thing I would like to add is, apart from renal and audiometry, I would suggest that we do a cardiac evaluation also, because your cardiac function is very important, because you are going to push in some 4 liters of fluids when you are giving cisplatin. And that again, poor cardiac function is again a criteria to decide whether the patient is eligible for cisplatin or not. And second point is for those who are ineligible for cisplatin, we have our own Indian trial. We can replace it with the docetaxel. So that's a Tata trial. I would suggest that, no, I understand that you are a surgical candidate, but I would suggest that you at least read through that trial because that's very important because that's a phase 3 trial done in India.
Okay, sir.
Okay. So beside that,
Anand, for a T3N0, do you want to ask him what fields? Will you cover bilateral neck? Will not cover bilateral neck?
yeah. So that becomes a core radiation oncology thing.
Okay, but you should know at
But
least
anyway.
you should know basics of
Yeah.
radiation.
So,
Dilip, what will you do? Answer, Anand.
Sir,
So, what are the elective neck levels that would you irradiate?
so usually
that's the
from
question sir is asking.
2 to 5, usually we will radiate for bilateral. If it is a depend upon the subsite, sir. If it is a subsite supraglottic, I can
So
include.
what would you dissect if you are doing a surgery?
Sir?
What are the levels that you dissect if you are doing a surgery?
If I'm doing the surgery, most of the supraglottic cancers, I include 2 to 4, sir. And if it is a
Same side or same side or both sides?
Bilateral, sir.
Okay. So the same with radiation as well. Okay. So if you're going for a concurrent CTRT, it will be 2 to 4 if it's an N0.
Yes, sir.
Okay. So usually the dose, do you have any idea about the dose?
Sir, 70 gray usually given in the literature, sir. But especially in concurrent radiation thing, but depend upon the local protocols, the doses will be some 60 to 65 gray is.
Okay, 60 to 65 will be suboptimal. Anyway, so whenever you are telling about radiation, you always tell the fraction as well. Okay, 70 gray in
35 fraction.
35 fractions. Okay, so usually the dose in a radical setting will be 66 gray to 70 gray. In 33 to 35 fraction will be the usual dose. Okay, 60 to 65 will be a suboptimal dose. It may be used in a post-operative setting, but not in a radical setting. So along with the concurrent cisplatin, 3 weekly is the evidence is based on 3 weeklies, 100 milligrams cisplatin. But most of us in India practice 35 to 40 milligram per meter square, depending on whatever the condition is. Okay. So, and the neck elective radiation will be at a lower dose. Usually the elective, when it is an N0, the elective neck will receive somewhere around 50 gray.
Oops.
In 25. Okay.
All right. Anything on the chat? Any other further questions? We can discuss Asim laryngectomy and its complications in the T4 in the next stage. Today we discussed organ preservation, induction, concomitant, if you cisplatin eligible and all that, and surgery and the complications and the details of surgery.
We'll discuss that separately, sir. We'll discuss that separately.
Because that is a topic by itself and a huge topic. So great, Dilip, you've done well. But structure answers a little better, and for every answer that you have, for every question that we ask, structure your answer and know the reasoning why you're answering. Okay? That's all I'll tell you. Take over, Asim.
Thank you, everyone. Thank you, everyone. Thank you, all the examiners. Thank you, Dilip. Thank you, Dr. Seiichi Yoshimoto. It was a great discussion, good presentation. We'll meet again next time with a new topic and new presenter, a new set of moderators. Thank you very much.
Thank you.
Thank you very much, all.
Thank you. Bye.
Bye, sir. Thank you.